All right, this is it, the final part of our deep dive into posterior circulation stroke. We're moving from just recognizing the patterns to taking decisive action. Because, let's be honest, knowing what's wrong doesn't save any brain tissue if you don't act on it. So let's jump right in.
And this right here is the absolute heart of the problem we're tackling today. These words are so important. A normal, non-contrast CT can give you this dangerous, false sense of security, and it's a trap that can lead to absolutely devastating delays. We're going to build the framework to make sure you never fall into it.
And the stakes couldn't be higher. Get this, a staggering 35% of posterior circulation strokes are missed during that initial presentation. That is more than 3 times the rate for anterior strokes. It's a huge number, and it tells us we can and we absolutely must do better.
So why is that number so tragically high? Well, it all comes down to what we call the diagnostic gap. Think of it as this dangerous gray area, this clinical overlap, where a potentially fatal stroke looks almost exactly like a harmless inner ear issue.
So here's the trap. A tiny little infarct, tucked away in the cerebellum or brainstem, can show up with nothing more than vertigo, some nausea, and a bit of unsteadiness. And to you, standing at the bedside, that patient looks for all the world like they have vestibular neuritis. This clinical mimicry, this stroke masquerading as a benign condition, is the #1 reason they get missed. So, how do we see through the disguise? How do we bridge that gap? Well, it all starts at the bedside, long before you even think about ordering a scan. This is all about arming yourself with the clinical clues, the red flags that should make your brain switch from thinking benign vertigo to potential stroke.
Think of this as your vertigo-plus mental checklist. The patient has vertigo, plus what? Actively hunt for the plus ones. Ask yourself, are they seeing double? Is their speech even a little bit slurred? Any trouble swallowing? Numbness on their face? And this one is huge. Watch them try to sit up or stand. If they can't do it without help, that is a massive red flag for a cerebellar problem.
Now this right here is a classic, high-stakes mimic you have to know. Acute vertigo plus sudden hearing loss. That combination should set off alarm bells in your head. It screams ACA territory stroke, that's the anterior inferior cerebellar artery. You absolutely cannot afford to label this as labyrinthitis or vestibular neuritis. Okay, so your bedside exam raised a big red flag. Your clinical suspicion is high. Now what? Now you have to prove it. And that brings us to the imaging ladder. It's not just about ordering a scan. It's about ordering the right scan in the right order for the right reason. And wow, does this chart drive the point home. Let me say it again. A normal CT does not mean a normal brain. Just look at that first bar. A non-contrast CT can miss up to 90% of acute strokes back there. Its only real job is to rule out a bleed. To actually see the problem, you need a CTA to look at the vessels, and ideally, you need an MRI with DWI. That's the gold standard. Okay. Let's break down the job of each scan, nice and simple. A plain CT, that's your hemorrhage detector. That's it. It cannot rule out a stroke. A CTA, a CT angiogram, now we're talking. This is crucial for spotting a large vessel occlusion, or LVO, that you might be able to treat with thrombectomy. But to actually see the dead brain tissue, the infarct itself, you need an MRI with DWI. And an MRA gives you that extra beautiful detail on the arteries themselves.
All right. You've confirmed the diagnosis. Now the real race begins. We pivot from investigation to intervention, and from this moment on, every single minute, every second matters. This isn't just about being right. It's about being fast enough to actually change the outcome for this person.
You've heard it a million times, time is brain. And these are the numbers you absolutely have to burn into your memory. For IV thrombolysis, that's the clot-busting drug TPA, you've got a 4.5-hour window from symptom onset. But here's the game changer. For posterior strokes, for large vessel occlusions, the window for pulling that clot out, mechanical thrombectomy, can extend all the way up to 24 hours in some patients. That is a massive opportunity to save a life. And this is so important. Management is not a one-track process. It's a parallel process. While one team is rushing to get the vessel open, another team has to be watching like a hawk for complications. We're talking about swelling in that tight posterior fossa space or the stroke converting into a bleed. Both things have to happen at the same time.
So when do you pick up the phone and make that urgent call to neurosurgery? You need to know these triggers cold. It's all about size and effect. A cerebellar infarct that's bigger than 3 centimeters, any cerebellar bleed at all,
or any sign of hydrocephalus, that's fluid backing up and squishing the brainstem, any of those means an immediate stat call to the neurosurgeons.
Once you're past that initial hyperacute phase, the work isn't over. Getting the patient to a dedicated stroke unit is absolutely key. This is where we fine-tune everything, getting tight control of blood pressure, managing blood sugar and temperature to protect the brain, and performing those constant neurochecks to catch any little change early. And of course, being incredibly careful about aspiration risk if they're having trouble swallowing.
Okay, we have covered a ton of ground. I know that was a lot of information, so let's distill all of that down to the 3 things you have to walk away with. If you remember nothing else, remember these.
First up, normal CT is not normal brain. I'm going to keep saying it. Never ever let a clean, non-contrast CT talk you out of your clinical suspicion. Number 2, the clock is ticking, but it might be ticking for a lot longer than you think. Don't write someone off because they're outside the TPA window. For LVOs, you could have up to 24 hours. And finally, number 3, size matters. Remember that 3-centimeter rule. If you see a cerebellar infarct that big or any bleed, it's a neurosurgical emergency. No hesitation.
And that brings our 3-part series to a close. We've gone from the basic anatomy through all the specific syndromes and now to red flags and treatment. The goal of this series was to give you a new mental model, a new framework. Now you have it. You have what you need to catch the posterior stroke the scanner is likely to miss.
If you want to keep digging deeper, please subscribe to Australian Dizziness Clinics on YouTube. And be sure to visit us at australiandizzinassclinics.com. We've got the full clinician library there with cheat sheets, literature reviews, and our whole emergency medicine series. Thanks so much for watching.